Evolution. Excellence. Knowledge. Hybrid Rhinoplasty Excellence Training.
Y la experiencia ha sido absolutamente espectacular.
Si quieres ser mejor, tienes que aprender de los mejores.
La parte de disección en cadáver, pudimos aprovechar todo lo que nos han enseñado.
HRED 2024. Miami, USA.
Es de una experiencia totalmente recomendable.
Tenemos estos cambios innovadores de la rinoplastía híbrida y la rinoplastía conservadora del dorso.
Doctores de 15 países, las pláticas espectaculares, Cadaver Lab es primer mundo.
Y todos hemos tenido desde el primer día un acompañamiento bastante cercano, que es importante.
Com todos os mestres que vêm aqui, né, você consegue aprender cada coisa, cada pequeno detalhe, né?
The best surgeons in the world together to a unique experience. Totally hands-on.
Vas a aprender todo lo que todavía, esos pequeños tips que te faltan y que siempre tienes que estar preparándote.
Técnicas, detalles y la experiencia en los cadáveres, la verdad que da una seguridad increíble, el hecho de poder tener un tutor al lado.
Technique, technology, safety. Come with us to the future of hybrid rhinoplasty.
Me siento como en una familia acá.
Y qué mejor que complementar con una práctica en disección de cadáver para reafirmar todos esos tips que hemos aprendido. De verdad.
E tenho certeza que depois do evento eu sou um cirurgião de nariz melhor e tenho certeza que todo mundo vai levar bastante aprendizado aí para casa.
Evolution, knowledge and excellence. September 2024. Subscribe now. Okay, my friends, rhinoplasty lovers, I have a huge pleasure to be here in our live talk today with my brother, Valerio Finocchi. Valerio, I consider him not only a friend, but I have a big admiration for what he is in person, but also as a surgeon. I had already the opportunity to go to Rome and spend some days with him and learn a lot from him. And I think he's one of the best rhinoplasty surgeons nowadays in the world. So my friend and brother, Valerio, thank you so much for being here and taking your time.
It's always a pleasure, and I have same admiration for you. So it's a pleasure to be here with you.
Yeah, and Valerio is one of our special guests this year in our course in Miami that is going to be in September. And one of the reasons why I invited Valerio is not only because, as I said, he's one of the best rhinoplasty surgeons in the world, but he developed a technique that it's called SPQR. And most of you guys, rhinoplasty surgeons, already heard about that or already know about that. But in my opinion, if you learn dorsal preservation, one of the techniques that you have to have in your arsenal is the SPQR, is the low strip. Because there are some cases, especially in crooked noses, deviations, I think it's the best technique. And Valerio, I think, does this technique in almost 100%, correct, Valerio?
Yes.
Yeah, almost 100%. And as I said, the reason why I invited him is that in our course this year, it's a very exclusive course. I don't want to have hundreds of students there. I want to have a small amount of students, but you can have the opportunity to be in close contact with the professors. And Valerio is one of the professors, but Valerio does in almost 100% of his cases low strip. And on the same time, I invited other surgeons who does high strip in almost 100% of the cases. And also other surgeons who does structural rhinoplasty in almost 100% of the cases. And other surgeons like me, for example, that we mix. Sometimes we do structure, sometimes dorsal preservation, high strip, low strip, middle strip. So we're going to have an amazing discussion there, Valerio. And thank you so much for accepting this invitation.
Thank you.
And Valerio, before you start your video, Valerio is going to show a video today about his technique. But before showing your video, Valerio, your technique, as I said, is amazing. But on the same time, for people who are starting, sometimes it feels a little bit challenging because people are used to preserve the L frame, and sometimes when they see releasing as a swinging door on the first time, they feel a little bit scared. So how do you think cadaver dissection courses are important to learn your technique? Because I think cadaver dissection is an opportunity for people to lose their fear in some techniques and understand exactly the techniques. And as I said, this course is not like a huge course that people cannot talk to you. Sometimes I can go to a meeting, see Valerio, see his lectures, but I cannot talk to you. And there, they're gonna see you demonstrating in the cadaver, and they can ask you, how do you fix the septum again in the nasal spine, for example. So tell me, what do you think about the importance of this kind of courses in the training of the surgeons?
Yeah, basically, I had the same problems and fear when I was a student, when I was trying to, for example, learn a facelift, and I had the best improvement I had. It was because I could do the cadaver dissections. So I understand the anatomy, and the anatomy of the nose is three-dimensional. It's even more difficult. So as you will see in the video, if we remove some parts of the skin and we can really visualize what is happening under the skin, under the soft tissue envelope, so we understand better the movements, because the difficulty of this technique is that it's not static technique, it's a dynamic technique. Because if you understand that how the joint moves, why the joint stay in that position that is flexed, and how you can release it to extend the joint, and also to stabilize the tip. Because, you know, if we do L-strut in almost, I don't want to say 100, but almost 90% of the cases, you should use a septal extension graft. While with this technique, when we release the joint and we release the flap of the quadrangular cartilage, the quadrangular cartilage extends forward and becomes a septal extension flap, which can stabilize the tip. So it's important to understand the anatomy. It's important to understand the biodynamic of the joint and how we can use this biodynamic to reverse the process, because we talked a lot with you about the reversal rhinoplasty. If we understand the process that caused the deformity, so for example the hump or the deviation of the pyramid, then we can reverse the process and bring that nose where it was before the deformity. So it's amazing that you can visualize on the cadaver, you can understand better the technique, and then you can go back after the Congress with everything in your mind. With I will show you how to be safe, how to avoid the mistakes that I did when I was starting approaching this technique. And in this way you will avoid problems, post-operative problems. It's if I could go back, I would love to be part of this course, because I would avoid a lot of problems that I had while I was creating the steps. because I was thinking I was doing right, but I was doing wrong because I was missing little details that now, after many retouches, I understood. And so now my retouches go down a lot because I check every detail and I'm sure that the joint is released, that everything is stable, and that the nose will heal how I live in the operative table.
Perfect, perfect. Well, for you that are watching us here, Valerio, I think you are brilliant, my friend. And because you turn some things complex in a simple way. And I'm going to explain why. First, if you're watching here, if you want to do some kind of dorsal preservation, SPQR, Valerio's technique, is one technique that you have to understand and you have to have in your arsenal. Okay, so I think it's something that you cannot put it on your side and don't learn it. You have to learn. Second thing, the concept of reverse rhinoplasty. Valerio will talk about this in the course. I think this concept, Valerio, you created. You got something a little complex and turned into something very simple to understand with your concept. And I think that was brilliant. It's something that everybody's like, okay, I know what it is. But when you say reverse rhinoplasty, it seems that everything becomes clear in the surgeon's mind. And that's what happened to me when you explained me that. And the other thing that you said now, structural rhinoplasty is static, right? It's an static surgery. You cut there, remove, and you suture, and it's not moving. And when you do preservation, especially SPQR, it's dynamic. So that's another concept that you turn in something very simple that people don't think. And I was not thinking this way also. And when you think that preservation rhinoplasty is dynamic, you start to understand the philosophy in a very different way and understand that what you're doing is special. It's not only, okay, it's another technique. No, it's something that really can change your results, can change your outcomes. And the last thing that I want to talk here is that every surgeon that I invited for this meeting, including myself, including Valerio, we're going to have a session of complications, because that's something that we don't talk in the meetings. And I want every surgeon to bring their own complications, their worst complications, but on the same time, their most common complications. Because for the student, I think that's amazing, because we learn a lot from our mistakes. And when we share that, we can help other people. And I'm going to put in a round table the masters showing their most common complication, how they deal with that. Valerio is a surgeon that is really honest and really Valerio doesn't have is not that kind of surgeon that say, okay, my results are very good, I don't have complications. And Valerio always shared with me in a very honest way his complications. And thank you so much, Valerio. That has a lot of value, and you're bringing a lot of value to our course. Thank you so much.
Thank you.
Yeah, and feel free, please, to share your screen and show your video, and then we can discuss a little bit more.
Okay. Okay. So this is a dissection I did. Can you see it?
Yes, perfect.
Okay, this is a dissection I performed to show the technique. I already dissected everything, so in this way we will be faster. And as you can see, one side has the soft tissue envelope covering the dorsum and the tip. The other side, we can see the bony vault, the cartilaginous vault, and the lateral crura. So here I already dissected the mucoperichondral flaps. and I'm gonna start performing the swinging door septoplasty. The swinging door septoplasty basically means that you release all the quadrangular cartilage from the bony attachments. The only part of the quadrangular cartilage that will be left attached to the dorsum is from the rhenium to the anterior septal angle, okay? And here you can see on the drawing that I start from the posterior septal angle, I follow the quadrangular cartilage attachments along the maxillary crest and vomer. I arrive to the chondrovomeran joint, I go back along the perpendicular plate of ethmoid junction until the E point. The E point is the most anterior part of this junction, and then from the E point I go back to the rhenium. Okay, in this way you are sure that you release all the quadrangular cartilage. This is very important because if you don't release it well, you will have the patient coming back after 1 month with the amp recurrence. Okay, so here in the endoscopic view, you can see I'm releasing the quadrangular cartilage along the perpendicular plate of the ethmoid junction until the E point. Okay, so I am now exactly below the bony cap. Okay, but it's not enough, because if you keep the segment between the E point and the rhenium, then it means that the flap cannot really move along the sagittal plane, and probably you will suture it with some tension on the anterior nasal spine, and this tension 24 hours will cut the stitch, and you will have the flap will go back, and if it goes back, the joint, so we know that the dorsum is a joint, is a synchondrosis. It will flex again, so you will have a hump again. Okay, so it's very important that you check that the quadrangular cartilage is fully released, so it has to be attached between the rhenium and the anterior septal angle. That's all. I made a lot of mistakes because I was not checking it very well, and I had to bring the patient to the OR to fix the amp recurrence. So this is the first thing you will learn during the course. And after this, let's see if I can go a little bit faster. Here we are gonna show you how to decide the site to do the osteotomy, because the osteotomy is one of the most difficult things that a surgeon has to learn. Why? It's more difficult compared to structure rhinoplasty, because, as we said, it's dynamic. So when you will move the joint, something will happen not only at the level of the profile, but also laterally. So the most difficult part is this corner, okay? Because when you cut it, here the thickness change a lot. And if you make a mistake when you are making the cut or the ostectomy, according to the case, and then you're gonna move the flap and change the profile, also the bone here, the corner moves, usually go cranially. So if you didn't cut very well and the thickness of the bone is a lot, then it will create a blocking point, and the joint cannot extend how it should. Okay, so it's very important to understand how the thickness can change at the level of the medial canthal area. That's why we perform usually a sort of, we call banana osteotomy, because at the level of the banana, this kind of banana is a line where the bone is thin, so it will not create blocking point. And on the cadaver is amazing because you can really go and see the thickness of the bone, so you will understand much better how to decide the site of the osteotomy. Then let's see. Okay, so here you can see the perpendicular plate of the ethmoid, which is another blocking point that we should control, because otherwise, if you try to mobilize the pyramid when the perpendicular plate is still attached, you can have problem along the skull base. So it's very important to isolate the pyramid from the skull base, because we don't want to transfer any energy to that area. Otherwise, there are other complications that can occur. So it's very important to use the right instruments. In this case, I'm using baby ronger, because with the baby ronger, I can really cut and remove the amount of bone that I want. And to be sure that you are removing the right amount, there is a trick with a forceps, long forceps, that you enter and you can control over. So one blade will go in and one blade will go out, and in this way you can check exactly that you arrive until the radix, because you want to be sure that you release. You see, okay, one blade in, one blade out. So we want to be sure that we arrived until the radix. If you see that you didn't arrive yet to the radix, it means that you have to remove a little bit more. So all these things you can do on the cadaver and understand, because otherwise, if you try this on a patient, you can be really nervous, because you can have blood, you are nervous, so maybe you forget a step, and in this way you can have all the time to understand what you are doing. So you see here, I cut the perpendicular plate, and I have to be sure that I arrive until the radix. If I'm not, it means I will keep doing it until I'm sure that I reach the radix. Then here you can see we are performing the first, this is a low to high, because we want to do the banana. We already made the transverse. Usually we do the transverse percutaneously, and low to high endonasally. And at the end, I do the radix osteotomy. Usually I do from lateral. I like to do lateral because it's easy, because you want just to mobilize, fully mobilize the dorsum. There are other ways, like you can do out, in, like from this direction, but I don't like, because I don't like to transfer energy in this direction. If I have to do from endonasally, I prefer to do in and out. Okay, but in my experience, I do in 95% of cases in this way. So from lateral. Okay, it's okay. And after I perform the osteotomies, I'm ready to remove the low septal strip. So as you can see here, I'm controlling the rotation of the flap. I want to be sure that I have an effect on the joint. I'm removing here the low septal strip. You will learn that it's important to remove less anteriorly and more posteriorly, because otherwise the corner of the guanar cartilage touch the maxilla and you cannot extend. As you can see, after you remove the low septal strip, you have a lot of space to make the rotation, and you can see exactly the amount of rotation. Sometimes, if you rotate too much, you can create a sort of breaking point along the renion. This for me is a mistake, because I don't like curvy dorsums unless the patient requests this kind of result. I prefer to have a flat dorsum and a supratip breakpoint. As you see, when you extend the flap, you have a lot of excess caudally. So it's important to remove the right amount, but not too much. Why not too much? Because we want the anterior septal angle to be something that gives power to the projection of the tip. And here you can see when I'm rotating the flap, the dome are push it forward, so you can decide the projection without any septal extension graft. I have to say that this technique for me now works without any graft if I have thin to medium skin. So probably in Brazil, where you have a lot of thick skin patient with not very strong cartilage, you can even do this flap plus a taco or plus septal extension graft side to side, as you like. Because the problem of this kind of skin is that they are heavy, they push a lot, they have a lot of scar. So there are cases where I do this technique plus septal extension graft, and you can use the low septal strip, or you can use even other cartilage that you take posteriorly. We already talked about this issue with you, Fernando. So here I'm fixing the flap to the anterior nasal spine. Then I decide exactly where I want the tip. So I do a lateral crustile, as Dr. Checker taught us. So I change the dome position, and when you do the lateral crustile, what is happening is that the tip rotates. So it goes already over the anterior septal angle. And let's go forward. I put the hemidomal stitches, and here you can see you can fixate the interdomal ligament. You can fixate on the WASA segment. So in this way, you are sure that the tip cannot go forward. If it can't go forward, it cannot drop, because there is always cannot go. It's a blocking point that you create. It's important to have a strong WASA segment. So if you see that the WASA segment is weak, it's better to reinforce. It's better to use a septal extension graft. Otherwise, this cartilage, if it's not powerful, tip will drop a little bit, maybe 2, 3, 4 millimeters. But 2, 3, 4 millimeters is a lot, because the profile change, and the patient will come back to you and say, my tip is not beautiful as it was at the end of the surgery. So these concepts basically are structure concepts, okay? So we are mixing the philosophies. We learn a lot from each other, and it's important to stabilize the anatomy, because our worst enemy is the scarring process, is the healing process. You finish the surgery, you're really happy, you think you made a wonderful nose. Patient come back after 1 month, 2 months, 3 months, and it's not the same nose. So if you have a structure that keeps the anatomy in that situation, so it will be forever, almost forever, let's say, at least 5 to 10 years. Okay, so we have to use both philosophies to have a good result. And I really learn a lot from structure as well. So here, another thing that you will see is that when you rotate the tip, you will have a conflict between the upper lateral cartilage and the lateral crura. So the caudal border and the cephalic border of the lateral crura go in conflict, and this can create two problems. First, internal nasal valve problem for breathing. Second, counter rotation of the tip, because it's a force that is pushing forward the tip. So you don't want any conflict. You must have a sort of primary touch between these two cartilages. Okay, and one way to understand, if you are on cadaver, you can see very well. If you are in live on a live patient, I always go and check the internal nasal valve, because I want to see that there is nothing that is coming in the valve. If I see that there is a caudal border, I go back in, I remove more. I want to see that it's open. Okay, so here now I'm removing all the wall because I want to show inside the swinging door septoplasty. So here you can see, sorry, because we didn't edit this video. Here you can see the release. Here you can see the rotation, and you can understand much better what I'm gonna stop, because this is very important. Wait, okay. So I release everything, okay? So the cartilage is fully free. I reach the E point. E point is here. It was here, okay, but now it's here. But anyway, if you remember, I removed this bone. So imagine that the bone was arriving here, but the rhenion is here. So this segment, if you don't release this segment, the cartilage cannot rotate forward and anteriorly. And this segment is the E point to rhenion. Okay, you can see here that I didn't release very well. It should be even more released, because you have to be sure that goes until the rhenion. Otherwise, this little cartilage can ruin your result. Another good thing about this picture is that you can see that this cartilage is giving structure to the rhenion. If you do another kind of septoplasty, swinging door septoplasty, which make the cut exactly here and then goes obliquely, what happens is that when you rotate the flap here, you will have a space, dead space. And this dead space is not supporting the rhenion. If you have this cartilage, you are supporting the rhenion, so you will not have any depression after in the result. So here I'm completing I'm showing how it works the baby ronger. So the trick is that you don't have to make big bites, but you have to do small bites. And let me check what else. Okay, here I'm showing that it's very important to make a good cut. So you have to be sure that you arrive to the rhenion. And you can see if we release the stitch, you can see that when you release it, you have a backward rotation and you have a flexion of the joint. Okay, so you can really understand much better the biodynamic of the joint. You see, when I extend, what happened? It was like this, then I extend, and I can have a straight profile. But you see, this little piece can be the problem. Sometimes it's not, okay? Sometimes it's weak, so it's not pulling back the flap, but it's much better if you complete it, as I'm doing now. Because in this way, there will be no tension. Tension is an enemy, okay? I think we did everything. We said everything. So let's go
Amazing.
back.
Amazing, Vale. Well, I think with this video that you showed, we can see really the importance of cadaver dissection, right? Because this kind of dissection is not a dissection that could be done in a patient, of course. So when you're doing in the cadaver, you can watch inside, you can open the lateral wall and understand, as you said, the dynamics, right? The movement. And I think that is essential, especially that tricky part of the rhenium, okay? Because in my hands also, that was a tricky part. Last time I visited you, you were already teaching me this, that the cutback and leaving a little cartilage there, not to have a depression, because you taught me that if we go very close to the roof, sometimes we have a weak point there, right, of the cartilage.
Yeah.
Right. And Vale, when the hump is a little bit more cartilaginous, like there is a little curvature on the cartilage, do you go a little bit to the front, the cutback there, or do you go into the highest point of the cartilage?
If there is an intrinsic curvature of the cartilaginous dorsum, I'm gonna do how Dr. Robotti described, but Dr. Robotti is remodeling the cartilaginous dorsum with high septal strip.
Yeah.
Varish started to do with the low septal strip. So what I do, I cut the insertion of the upper lateral cartilage to the septum, and then with the blade, if it's the septum deformity, I just cut the curve. If the problem is made by the curvature of the upper lateral, then I cut with the scissors, I make straight. If you want, you can reconnect. If you see that they are stable, it's not necessary. This is the way I do.
We're preserving the mucosa, right?
Yeah. The mucosa attachments under I preserve. So I first dissect. If it's a small curve, you don't need to dissect. You just with the blade you cut. If it's a lot of curve, it's better to dissect the mucosa between the upper lateral and the mucosa side. So in this way, when you're gonna release the insertion, you don't create a dead space. So this is important for the stabilization of the dorsum. Otherwise, you can have inverted V, and then you have to do something like structure, put graft. So it's important to keep that mucosa.
Perfect. Well, as I said, we're going to have a session only about complications, but when you do everything that you showed and you still have a little hump after 1 month, do you do the revision or the touch-up rasping the cartilage or the bone, or do you go to the septum again? And with how many months you do the touch-up?
Okay, I will be very honest. I'm kind of I don't know how to say in English. The word is not coming in my mind. We say in Italian pigro. It means that I don't want to redo the surgery. If I have to do the retouch, I want to be fast. So if I want to be fast, I rasp.
Okay.
But
If it's cartilage, do you cauterize?
no, I like this idea of decolorization, but I don't do it. I use the blade or the scissor. And about the time when to do it, it depends. Because one thing that you will start to understand during this course is that it's possible to change the profile of the nose in some cases without dissecting the soft tissue envelope. Yeah. So if I did SPQR V2, that means that I didn't dissect the soft tissue, I can revise after 1 month because there is no surgery at that level. Yeah. If I did SPQR V1, I wait at least 6 months. I say at least because depends on the case. Usually we know that we should wait 1 year, right? Yeah. But I don't agree. In some cases, yes, it's better to wait 1 year because maybe the scarring process is so strong. But if I feel with my finger that everything is soft, I can go 6 months after. And as I do mostly close approach, the recovery is faster. So I can do at 6 months. It depends. You have to evaluate the case. You have to touch. You have to see how the patient psychology is, because sometimes they push you a lot because they don't want to see. One trick that I use to take time, sometimes I use fillers. Like if I see the recurrence, I was doing this in the past when I had a lot of hump recurrence. Now it's happening very rarely. But anyway, I was putting some filler to hide the hump, so the patient doesn't care about she almost forget it. But after 6 months, maybe reabsorb. So the patient will contact you because you want to fix the problem. Okay, now it's ready. You can do it.
Perfect. Well, Valerio,
I don't like fillers, but sometimes they can be your friends.
Oh, sure. I also use it sometimes. Vale, I just want to thank you because it was amazing, very nice video. I think for people who are watching us, they could see exactly how it's important to do a cadaver dissection. As I said in the beginning, I think your technique is something that you must have in your arsenal. It's not there are some dorsal preservation techniques that you can choose not to have in your arsenal. You can say, oh, okay, I don't need to learn this, because nowadays I know there are so many techniques. Sometimes it's difficult for someone who is starting to learn everything and to master themselves in everything. But I think your technique you must have in your arsenal, because there are some cases that it's essential to do the low strip. And we had last year, Vale, we limited the limitation of the Mark Institute was for 40 students. So we completed the places, and then we had for this year almost 600 people in the waiting list. So we're trying to put more people than 40, but there are limited spots. And I think people who go there will have an amazing experience, because, as I said, I'm bringing strategically people with different philosophies, different techniques, so the student can go there, can learn everything, can choose what is best for their practice or for their patients. And because it's exclusive course, they have the opportunity to have a close contact with the masters like we don't have in big meetings. So thank you again, my friend, for accepting the invitation.
Thank you.
We're going to be in September many days together, right? We have we have the bike tour, and then we have the course in Miami. And thank you so much. I know your schedule is so tight with a lot of surgeries, a lot of patients, and you separated this time to be with us there. I'm very thankful for that.
Thank you. Thank you. It will be fun, and we love to teach people, so it will be an amazing experience altogether.
Okay. Thank you, Vali. So have a nice evening there in Rome. And thank you again for everything, my friend.
Thank you. See you soon. See you in Miami.
Yeah, before, see you in Sicily.
Yes.
Bye-bye. Thank you.
Ciao, ciao. Bye-bye.
Once upon a younger year, when all our shadows disappeared, the animals inside came out to play. Went face to face with all our fears, learned our lessons through the tears, made memories we knew would never fade. One day my father, he told me, son, don't let it slip away. He took me in his arms, I heard him say, when you get older, your wild heart will live for younger days. Think of me if ever you're afraid. He said one day you'll leave this world behind, so live a life you will remember. My father told me when I was just a child, these are the nights that never die. My father told me. Light a fire they can't put out, carve your name into those shining stars. He said go venture far beyond the shores, don't forsake this life of yours. I'll guide you home no matter where you are. One day my father, he told me, son, don't let it slip away. When I was just a kid I heard him say, when you get older your wild heart will live for younger days. Think of me if ever you're afraid. He said one day you'll leave this world behind, so live a life you will remember. My father told me when I was just a child, these are the nights that never die. My father told me. These are the nights that never die. My father told me. When all our shadows disappeared, the animals inside came out to play. Went face to face with all our fears, learned our lessons through the tears, made memories we knew would never fade. One day my father, he told me, son, don't let it slip away. He took me in his arms, I heard him say, when you get older your wild heart will live for younger days. Think of me if ever you're afraid. He said one day you'll leave this world behind, so live a life you will remember. My father told me when I was just a child, these are the nights that never die. My father told me. can't put out. Carve your name into those shining stars. He said go venture far beyond the shores. Don't forsake this life of yours. I'll guide you home no matter where you are. One day my father, he told me, son, don't let it slip away. When I was just a kid I heard him say, when you get older